A very good
Yeah,
afternoon.
Dr. Vinay, I think we can start, right?
Sure, sir. Sure, sir. We'll start. A very good afternoon.
Any other judges expected? I'm not aware of.
No, sir. Even I am not aware of. We can start, sir. It's already 3:10.
Yeah. We'll start. I mean, you can ask the first speaker, Dr. Amrita, to start the session, I guess.
Yes, sir. Dr. Amrita, are you ready with the slides?
Yes, sir, I am.
Yeah. A very warm welcome for all of you, like for the COSCON 2021 Medical Retina session, like the second part. Can you please start? Like you can share your slides.
Sir, are my slides visible?
Yeah, it's visible.
Yes, sir. Good afternoon to judges and colleagues. Today, my paper is on association of proteinuria and estimated glomerular filtration rate with diabetic retinopathy and diabetic macular edema. Diabetes, one of the fastest growing healthcare challenges of the world, and India is set to emerge as a diabetic capital of the world soon. DR and DKD are the most common microvascular complication of diabetes, sharing a similar pathological basis behind them. Proliferative diabetic retinopathy and diabetic macular edema has been described to be the cause of severe visual loss. Diabetic macular edema being a sight-threatening condition that can occur at any stage of progression of diabetic retinopathy. The parameter for detection and follow-up of diabetic kidney disease here, the major one is glomerular filtration rate, which is a direct measure of the renal function and a stable biomarker of the disease. And albuminuria, on the other hand, reflects the glomerular injury by the breakdown of glomerular filtration barrier, so that the measure of the severity of the diabetic glomerulopathy is measured with albuminuria. My aim of the study is to evaluate the proportion of DR in hospital-based type 2 diabetes mellitus patients and to investigate the association between proteinuria and EGFR with the severity of diabetic retinopathy and diabetic macular edema. Mine is a cross-sectional study that was done in the Department of Ophthalmology between the April 2021 to September 2021 with a sample size of 46. Inclusion criteria was all cases of type 2 diabetes mellitus, and I've excluded any patients less than 40 years of age, patient with type 1 diabetes mellitus, any acute metabolic disorders, for example, diabetic ketoacidosis, and cases with other ocular illness that affects ocular circulation like vein occlusion or artery occlusion, and opaque refractive media where I cannot visualize the fundus, and previous intravitreal injection or PRP, which was done earlier, I've excluded, and pre-existing kidney disease or current dialysis that affects the renal parameters, I've excluded. Methodology, each patient with type 2 diabetes mellitus underwent a vision testing and anterior segment examination. And for grading of DR and the presence or absence of DME, I did a dilated fundus examination, and they were graded according to the early treatment diabetic retinopathy study. Urine protein was assessed by a dipstick method, and a baseline result of more than 1+ was indicates overt proteinuria. And estimated glomerular filtration rate I've calculated using the patient serum creatinine using the CKD EPI equation from 2009. And here the serum creatinine of less than 1.2 for females and less than 1.4 for males have been taken as normal. And the equation involves the race, sex, and the age of the patient. Coming to results, 46 patients that were included in the study, and out of them, 33 of them had diabetic retinopathy changes. And majority of the subjects were males, both in present and absence of DR groups. And the mean age of the population was 58. Amongst the subjects with diabetic retinopathy, majority of the subjects had EGFR of grade 3, which was 42%, and followed by EGFR of grade 2, which is 33%. And this was found to be statistically significant. Comparing the results between EGFR and diabetic macular edema, majority of my subjects with diabetic macular edema had EGFR of grade 3, 64%, followed by grade 2, 21%. And this was also found to be statistically significant. Comparing proteinuria with the severity of DR and diabetic macular edema, subjects with diabetic macular edema, majority of them had overt proteinuria, which was 57%, followed by trace urine protein, which was 28%. This association was statistically significant, but no significant association was found between diabetic retinopathy and urine protein. Coming to discussion, the damage to the small vessels in the retina and glomerulus from chronic hyperglycemia leads to the formation of advanced glycated end products, And this can lead to obstruction of the capillaries, and podocyte proliferation is reduced, leading to the pathogenesis behind the starting of diabetic kidney disease and diabetic retinopathy, and concomitant hypertension, which is present alongside, and oxidative stress also aids with it. High serum creatinine, low EGFR, and the presence of microalbuminuria were associated with increased risk of progression of sight-threatening diabetic retinopathy. And the concordance between the reduced EGFR and albuminuria also is much lower than in type 1 diabetes. Their relationship remains unclear in type 2 diabetes mellitus patients. So previous studies of the association between BKD and DR used only either proteinuria or EGFR as BKD markers as a single parameter or a single variable of renal function. And no data exists for the relationship of EGFR with DME or proteinuria with DME, or the combination, the impact of the combined renal parameters on the severity of DR or DME in Indian population. And in our study, there was a significant association which was found between severity of DR and presence or absence of DME with EGFR and proteinuria. Hence, they may not only be an important clinical marker for diabetic kidney disease, but also could be correlated with diabetic retinopathy. Conclusion of my study, there is an impact of combined renal function indicators, proteinuria and EGFR, on the severity of diabetic retinopathy and diabetic macular edema in patients with type 2 diabetes, making them an efficient screening tool. I will also like to conclude my study saying that the routine tests or simple tests such as urine analysis and serum creatinine, which are done mandatorily to closely follow the kidney function in every diabetic patient by the physician, will help to predict the risk for DR and also their progression. And also we can educate the patients about the importance of regular screening for DR for a prevention of blindness. These are my references. Thank you.
That was an excellent presentation. I just have 2 questions.
Yes, sir.
Any reason why less than 40 years was excluded in the study? Actually, we're seeing a lot of young type 2 diabetics with really terrible diabetic retinopathy and membranes nowadays. So any particular reason?
No particular reason, sir. Just because it was it's mostly seen in elderly population and a comorbidity have taken less more than 40 years.
Okay. And just one more question was there any patient who had a diabetic nephropathy but who did not have any diabetic retinopathy findings in your study? Anyone like that? No.
No, sir. No, as far as I've, first come for screening, I've not really found anybody without the involvement of the eye, only the kidney involvement I've not seen.
Okay.
Dr. Amrita, one question from my side.
Yes, sir.
In the exclusion criteria, like was the hypertensive patients were excluded from the study?
Yes, sir. Yes, sir. Hypertension patients were excluded, sir.
Because it was not mentioned there. Number one, hypertension itself can cause like
kidney changes.
Yeah, renal parameters to change. And second thing, like the medications used in hypertension, like AC inhibitors. Yes, so even those can cause like altered EGFR
parameters. Yes, sir. Okay. That I've excluded. Sir.
And yes. The third thing is the use of any drug history, like which can cause like renal diseases.
Yes, sir. Right.
Okay, those are the 3 things like which can. Okay, fine. Thank you.
Yes.
Yeah, we can go on to our next speaker, Dr. Kailash.
Hello.
Yeah, you're
Am I audible?
Yeah.
Hello, good afternoon, everyone. I'll be presenting on the topic a study on effect of good afternoon. I'll be presenting on a topic, a study on effect of diabetes mellitus and hypertension on ocular blood flow by color Doppler ultrasonography. Introduction. Diabetes basically affects 347 million people worldwide, and India being the diabetic capital of the world, 37.7 million cases are present in India, and type 2 is more commonly, adult onset is more commonly associated with diabetic retinopathy and is a leading cause for visual impairment. It affects ocular circulation, which may contribute to the development and progression of DR, And the exact nature of the ocular blood flow abnormalities in diabetes has not been established, but increased resistance in peripheral vascular bed is noted even before the appearance of overt diabetic retinopathy. Hypertension estimated to affect 1.13 billion people worldwide, and essential hypertension is frequently encountered in patients with ocular problems. Many have reported decreased blood flow in CRA in patients with hypertension and peripheral vascular disease. This information is lesser known and is important as any change in vessel supplying could affect the blood flow to the optic nerve head. The recent advances in non-invasive imaging techniques, such as color Doppler imaging, have improved clinical evaluation of ocular hemodynamic circulation. It is a useful tool when standard diagnostic procedures are difficult to be used in the presence of cataract or hazy media. And it has proved useful in ocular conditions such as glaucoma, venous occlusion, age-related macular degeneration, and anterior ischemic optic neuropathy. It is used for assessment of retrobulbar vessels like ophthalmic artery, central retinal artery, and central retinal vein, where we are looking for the peak systolic velocity, end diastolic velocity, resistivity index, and pulsatility index. The objective of this study is to study the ocular blood flow velocity in the ophthalmic artery, central retinal artery, and central retinal vein in patients with diabetes mellitus and hypertension by color Doppler imaging. Patients of age of 40 years and above with diabetes mellitus and hypertension of at least 6 months have come into the OPD of ophthalmology department. It's a cross-sectional observational study, and it's a study period for 3 months, and sample size is 40, and sampling method is consecutive sampling technique. Inclusion criteria includes who are willing to give consent attending the OPD of the ophthalmic department, ophthalmology, and patients above the age of 40 years. Exclusion criteria, patients having glaucoma and patients below the age of 40 years. Informed consent was taken. All the participants were evaluated with detailed ocular history, visual acuity, and examined under slit lamp biomicroscope for anterior segment evaluation. Detailed and examined with indirect ophthalmoscope for posterior segment evaluation, and evaluated by color Doppler imaging for the ocular blood flow. So these are the results that we got in our study. So basically, there were 3 groups that we found. Group 1 consisted of diabetes mellitus, group 2 was hypertension, group 3 was diabetes plus hypertension. And as you can see, 16 people out of 40 were in group 1, 8 in group 2, and 16 in group 3. And according to the distribution with related to the gender, we can see that the group 1 had more number of males, while the group 3, that is the diabetes plus the hypertensive group, had more number of female. And then this is the third table, distribution of participants with age. In this, we see that in the 50, the most commonly seen age group is 51 to 60 years old and 60 to 70 years old, where group 3, DM plus hypertension patients are most commonly seen. And fourth table is the distribution of the participants with and without the retinopathy, where commonly seen basically retinopathic changes are more commonly seen in diabetes plus hypertensive patients and in hypertensive patients. So this table is a comparison of the ophthalmic artery parameters amongst the groups using ANOVA. In this, we can clearly see that the peak PI pulsatility index is reduced than that's commonly seen in the normal range. And this is a comparison of the CRV parameters amongst the groups using ANOVA, in which we see that the RI, that is the resistivity index, is increased than that compared to the normal individuals. So this is a 2 tables showing a comparison of the ophthalmic artery parameters with between the groups with retinopathy, and the other table showing without retinopathy. It clearly shows that the EDV, that the end diastolic velocity, is reduced in furthermore reduced in patients with retinopathy than without retinopathy. And this is a comparison of the CRV parameters between the groups with retinopathy and without retinopathy, again showing that the end diastolic volume is furthermore reduced than that seen in the normal without retinopathy patients, and also the resistivity index increases in retinopathy patients than that compared to the non-retinopathy patients. So discussion. So our study shows that there's a deviation of blood flow parameters from normal values in all the 3 groups in both ophthalmic artery and central retinal artery and central retinal vein. Khandelwal in 2020 studied 46 subjects and reported that in ophthalmic artery of the diabetics, regardless of presence or absence of retinopathy, end diastolic volume was significantly reduced. and the resistivity index was significantly increased than the normal, which is similar to our study, but it's not statistically significant. Robert D. et al. In 1998 proved that there is a significant reduction in systolic and diastolic flow velocity of the arteries tested in hypertensive patients compared to those in the normal patients, which is similar to our findings. So in conclusion, though our study was done with a very small sample size, the results can potentially provide useful information regarding altered ocular blood flow even before the retinopathy develops. Also, our study shows that color Doppler imaging may be of prognostic value in times to come in detecting patients, those who are at risk of developing sight-threatening retinopathy. So financial disclosure is nil, and these are my references. Thank you.
Yeah, I have just one question, Dr. Kailash.
Yeah.
You have said in one of your slides that retinopathy changes were more common in diabetes plus hypertension as well as hypertension alone than diabetes. Any particular inference from your side, or like why do you think this could be? Observation from your study, anything that's
can you? I didn't get your question. Can you just repeat it again?
In one of your slides, you said that retinopathy changes are more common in. Can you go to the previous slide?
Yeah.
Previous diabetes plus hypertension. No, the slide with the smaller boxes. Yeah, I think in one of these itself. So you said that in group, the retinopathy changes were more in patients with diabetes and hypertension, as well as those with hypertension, than when compared to diabetes alone.
There's no such correlation as such, just that we, because of the sample size being very less, we could. We could. And also the duration and the severity of the disease the patients had were for longer time than that seen in the diabetic patients.
Okay.
It's a good finding. Like actually, many times, even after treating like very well, like even after doing 3 sittings of pan-retinal photocoagulation, even after giving like anti-VEGFs and all, still the diabetic retinopathy still progresses, or even in case of like hypertensive retinopathy or vascular occlusions also, it still progresses.
Yeah.
So there, like this carotid Doppler, definitely it will help. But routinely, we don't advise like carotid Doppler for all the patients of diabetic retinopathy patients, like because of the availability and the cost factor.
Yeah.
Yeah, true. Okay.
Thank you.
Thank you.
Okay. So,
hello, Puneet.
Yeah.
Puneet. This is Raghavendra, Puneet.
Yeah. Yeah. Tell me, Dr. Raghavendra.
Puneet, ನಾನು ಕಣ ರಾಘವೇಂದ್ರ.
ಗೊತ್ತಾಯ್ತು ಹೇಳಿ.
ಏನಿಲ್ಲ, ಅದಕ್ಕೆ ಅದು ಪ್ರಕಾಶ್ ಸರ್ ಹೆಸರು ಜಾಯ್ನ್ ಆಗಿದ್ದೀನಿ, ಅದಕ್ಕೋಸ್ಕರ 3 to 5
Okay.
Okay, you can continue, no problem. Okay, Puneet.
Okay, thank you. Next is Dr. Harshit Krishna.
One paper is over, I think, no, Puneet? Or this
2 papers are over. 2 are over.
Which was the first paper?
First paper was Dr. Amrita, Association of Proteinuria. Just a minute, Harshit.
Okay, sure.
The first paper was Dr. Amrita, Association of Proteinuria. 1329, and the second paper was 844, FP 844.
Yes, I joined in between second papers too. Okay, you can continue.
Right. Is it audible, sir?
Yeah, it's audible. Yes. You can start.
Good afternoon, everyone. My topic is a study on the levels of body mass index, C-reactive protein, and glycosylated hemoglobin in diabetic patients. It's a free paper, Medical Retina. My chief author being Dr. Ajay Kudwa. Nil financial disclosure. My primary objective is to assess the proportion of diabetic patients with retinopathy and without retinopathy, and also to find an association of body mass index, C-reactive protein, and glycosylated hemoglobin among diabetic patients with and without retinopathy. Diabetes causes an array of long-term systemic complications that have considerable impact on the patient as well as society. It's the most common microvascular complication of diabetes and the leading cause of legal blindness in the working age adults. Elevated blood glucose, longer duration of diabetics, and hypertension and hyperlipidemia. They were well accepted risk factors for the development and progression of diabetic retinopathy. C-reactive protein is the most extensively studied biomarker of systemic inflammation that has been reported to be associated with diabetes, endothelial dysfunction, atherogenesis, and micro or macroalbuminuria. Body mass index is used as a parameter to show that being overweight and obesity are the risk factors for diabetes mellitus. It's a hospital-based cross-sectional study with the place of study being the patients presenting to the OPD and the inpatients at AJ Institute of Medical Science, Macular. The statistical test used for independent sample t-test, ANOVA analysis, and Pearson correlation test. For all statistical purposes, right-eye was taken into consideration. According to American Diabetic Association, diabetes is defined by the following criteria: with fasting plasma glucose more than 126, 2-hour postprandial blood glucose more than 200, HbA1c levels more than 6.5, and RBS more than 200. A detailed history will be obtained from each patient, followed by a complete ocular examination, including determination of the visual acuity. Detailed fundus examination will be done using slit lamp and indirect ophthalmoscope. The patient will be subjected to C-reactive protein estimation via laboratory analysis and blood sugar profile for HbA1c levels. BMI as a common index of obesity will be calculated by dividing the weight and height squared. Weight is measured using a balance beam scale and height is measured using a wall-mounted stadiometer. Based on the fundus examination, patients will be categorized, and after which the results will be analyzed. The inclusion criteria being all patients diagnosed with type 2 diabetes mellitus, including those with retinopathy, patients willing to give informed consent, and the diagnosed diabetic cases at least minimum 1 year and started on anti-diabetic drugs. Exclusion criteria being patients not willing to give written informed consent, patients with previously diagnosed ocular disease, suffering from any systemic infective conditions, or type 1 diabetes mellitus. And among the results, this table is an independent sample t-test with highlighting the age being the mean age being 63 years in among diabetic retinopathy patients with a p-value of 0.01. This is again an independent sample t-test with mean HbA1c level showing 9.461 with a significance of p-value of 0.01 in diabetic retinopathy patients. This table is highlighting the HbA1c and ANOVA analysis of HbA1c with comparing with the different stages of diabetic retinopathy, which shows a significance of 0.01. Which is considerably significant as compared to the different stages of diabetic retinopathy. This is an analysis of CRP levels as compared to the different stages of retinopathy, which is again which was found to be significant of p-value 0.043. Analysis in BMI was the p-value was found to be 0.612, which was not statistically significant. In this study, among the 36 diabetic patients, out of which 78% of the patients had diabetic retinopathy changes, with majority of them having moderate NPDR changes. Of the diabetics which were included in the study, 56% were male and 44% female, with a mean age group of around 63 years, and the mean duration was approximately 15 years. The mean HbA1c levels was found to be 9.4, which was significantly elevated in patients with higher grade of diabetic retinopathy. The mean CRP level was found to be 27.2 and was considered significantly elevated in patients with diabetic retinopathy with a positive correlation of 0.043. The study proves to show no correlation between BMI as a risk factor for development of diabetic retinopathy. In a study conducted by Rui Zhang et al., showed significant association between diabetic retinopathy and HbA1c levels with high specificity. Our results were consistent with this finding. Conclusion: the prevalence and the grade of diabetic retinopathy is considered significantly increased with increased HbA1c levels. The current study shows that C-reactive protein levels showing significant correlation with diabetes mellitus, and hence it can be used as a reliable screening tool for diabetic retinopathy. It was inferred from the study that BMI is not a dependent factor for the development of retinopathy, although further study in the matter is necessary for a conclusive result. These are my references. Thank you.
I have just one question.
Yes, sir.
Was C-reactive protein levels elevated prior to the onset of diabetic retinopathy? Was there any such observation? or was it concurrent with diabetic retinopathy findings in
So
anything of that?
it was concurrent with the, it was statistically significant. It was correlated. So thing is, any patient presenting to the OPD as an inflammatory marker, they would have done CBC among inflammatory markers. C reactive protein would have been done, but
right.
There was no exact correlation mentioning that was it like before diagnosing retinopathy or after, sir.
Okay.
But then it was significantly elevated that.
Okay. Okay. Right.
Ashit, one more question.
Yes, sir.
Ashit, but C-reactive protein, is it very specific to diabetes?
No, sir.
Since
No,
because
no,
of
sir.
the
No, sir.
COVID days,
This I'm using only as a screening tool, as a predictor tool, sir, because not everyone would have gotten a dilated fundus examination done. So if I can just use it as a predictor tool, sir. So that
it's only a predictor tool.
Yeah,
but
yes,
there
sir.
can be fallacies, right?
There can.
Okay.
There can fallacies, sir.
Means fallacies means there can be associated. Because suppose there is any other
endothelial dysfunction
because of the COVID and all.
Yes, sir.
If
Yes,
the patient
sir.
is
CRP
COVID
is
positive
elevated.
also, like CRP is elevated. So
yes, sir. So this was just to use it as a screening tool, sir. That's all. So that
yes. Because there are many number of studies regarding CRP levels and diabetic retinopathy. But now there is because of this COVID, the CRP levels are little bit different. So you should see and correctly in your conclusion you have to take
yes, sir. In the
slow
exclusion criteria that I'll add, sir, patients who did not suffer from any COVID in the past.
Okay. Okay, didn't see. Sorry.
Yes. Another this thing is like, did you exclude patients of hypertension?
No, sir.
CRP levels is associated with the vascular stiffness and atherosclerosis. And that can lead to development of the end organ damage and the cardiovascular events. And many cohort studies have been done, like where CRP level itself will tell whether the patient is going to develop hypertension in future or not.
Yes, sir. Yes, sir.
So because like raised CRP levels, like even if the patient is hypertensive,
they will also present
CRP directly causes endothelial damage where even the diabetic retinopathy can progress.
Yes, sir. Yes, sir. Okay, sir. Sir.
Thank you.
Hello. Okay.
Yeah, we can go ahead with our next speaker, I think. Dr. Meera, are you ready with your presentation?
Yes, sir. Yes, sir. Am I audible, sir?
Yeah.
Yes, Meera, I can.
Yeah. Good afternoon, everyone. My topic, the study is on effect of diabetic macular edema on peripapillary arnophil thickness and ganglion cell thickness using spectral domain OCT. Myself, Dr. Meera, is the presenting author. My chief author is Dr. Nelly Nasrat. As we all know, there are pathogenesis of DR is associated with microvascular anomalies. Similar way, more and more new studies has proved that neural factors are also associated with diabetic retinopathy. So neural degeneration in diabetic retinopathy, it may cause neuronal apoptosis, the decrease in neuroprotective factors, in turn causing impairment of neurovascular coupling and retinal ganglion cell loss. So this was the background for my study. The aim of the study is to evaluate the effect of DME on the peripapillary arnophil thickness and ganglion cell thickness in type 2 diabetes patients. And objectives are to investigate the effect on DME on peripapillary thickness using SDOCT, as well as the thickness, ganglion cell thickness in patients with and without DME using SDOCT. It was a case control study carried out in our department from May 2021 to August 2021, and it included 36 cases. It was divided into two groups. Group A, 18 patients with diabetic retinopathy with macular edema, and Group B with without diabetic retinopathy patients without macular edema. And all the patients were evaluated for fundus and classified according to ETDRS classification. And patients with diabetic macular edema was diagnosed clinically as well as by OCT. The exclusion criteria was patients with type 1 diabetes and patients who gives a history of ocular trauma, any other macular degenerative diseases, ocular surgery, high myopics, or who underwent previous pan-retinal photocoagulation. And the established cases of glaucoma with or IOP is more than 21 millimeters of mercury with visual field defects were excluded from the study. Coming to my results, the mean age group was 56.56 years, and in non-DME group, the macular central foveal thickness was 23.39 micrometers, whereas in the DME group, it was 397.34 micrometers. And the ganglion cell thickness in non-DME group was 65 micrometers, and in DME group, it was 74 micrometers. And the RNFL thickness was greater in the DME group with 119.72 and DME group with 92.39, which was a significant RNFL thickness increment. And it was significant. It was compared in all quadrants, superior, inferior, temporal, and nasal quadrants. And there was a significant increment in RNFL thickness, particularly in the temporal and nasal quadrants. And it positively correlated with the ganglion cell thickness. Discussion, coming to the discussion. Although many studies were there, but there is no proven study where the DME truly influences the RNFL signal in significant manner. So in our study, it was found that DME is associated with increase in thickness of all the quadrants of the peripapillary layers, and the ganglion cell thickness was significantly greater in the DME group as compared to the non-DME group, and it indicates that the DME influences all the RNFL thickness in all the quadrants, superior, inferior, and temporal and nasal quadrants, and the RNFL thickness positively correlated with the severity of DME as according to the current study. And several studies, including many meta-analytical studies, has demonstrated the similar impact of DME on the RNFL profiles. Concluding, in this prospective longitudinal study, the RNFL thickness was increased in all quadrants in patients with DME, while it significantly correlated with the degree of the macular edema also. And these defects can be seen in RNFL of glaucoma patients, but there was no RNFL damages seen in the diabetic retinopathy patients, whereas large-scale study is required to understand the underlying mechanism and clinical implications of this data. These are my references. Thank you.
Hello.
Yes, sir.
Hello, Meera.
Yes, sir.
Meera, because see your conclusion, diabetic retinopathy usually will cause, because my thesis was also on diabetic retinopathy, similar studies only, because there will be a thinning in other quadrants. Only in the temporal quadrant, because of the macular edema, there will be increased this one. But you told that there is an increase in thickness in all the quadrants.
Yes, sir. In my study, what it was seen, all the quadrants, it was more, sir. There was increase in the RNFL thickness as well as ganglion cell thickness, and the p-value was significant in temporal and nasal quadrants, sir.
Okay. What is your opinion, Vinay and Puneet?
Sir, usually long-standing diabetic macular edema results will be resulted in like the RNFL thickening will be there in all the sectors, sir, including all quadrants. Only in short-term DME resolution will include like the temporal and nasal RNFL thickness.
Okay.
Yeah, I think there can be variations, particularly if there is a drill, disorganization of the retinal inner layers and all that.
Long term,
which is
mainly in the long-lasting DMEs, like it can result in thickness in all the quadrants. In a short-term diabetic macular edemas, like the thickening will be more in the temporal and nasal RNFL thickness will be increased, sir. And again, with the anti-VEGF, again the RNFL thickness will reduce. The main clinical implication is in cases of glaucoma, like where we should not do along with the diabetic macular edema. If there is a glaucoma, then we won't consider that as a thinning.
Okay. Because as far as I remember, my thesis I quoted like all there is a thinning, because I also did diabetic divided into two groups. So only I had
Yes, sir.
confusion.
Okay, sir.
Okay, thank you, Vinay.
Okay.
Thank you, sir.
Any other questions?
No, I think we can go ahead with the next speaker.
Yes, yes, yes.
Am I audible, sir?
Yes, you are.
Good afternoon, everybody. Today, I'll be presenting a cluster of cases that presented to our OPD in STM department during the peak of COVID time, that is last November. My chief author is Dr. Vishalakshi. I'm Dr. Sanjana Shri, presenting author. So neuroretinitis is an inflammatory disease characterized by optic disc edema due to increased disc permeability. This is followed by hard exudates that is seen in the outer plexiform layer and subsequently macular star formation. This entity was first described in 1960 as stellate maculopathy. And broadly, this is classified into infectious and non-infectious. This is a case series of 19 eyes that were examined. It is a retrospective study. 3 patients had unilateral involvement and 8 patients had bilateral involvement. Usually, all these neuroretinitis cases in which the etiology is unknown or later on diagnosed as idiopathic, they are usually unilateral. But in this series, we found that most of the patients had bilateral presentation. The median age of presentation was 25 years. They presented with acute onset, painless diminution of vision in the eyes, almost after 10 to 14 days. The visual acuity at presentation was 636 to light perception for distance. And low-grade ROPD was present only in 2 eyes out of the 19, and +1 AC reaction was seen in 4 eyes. Based on stage of presentation, the fundus examination showed vitritis, sphincter hemorrhages, subretinal fluid collection, hyperemic edematous disc, and macular edema, macular star. 9 patients gave flu-like illness exactly 2 or 4 weeks prior to the presentation. And 1 patient had confirmed viral meningitis and was recovering from it. After about 2 weeks, he presented to us. Diabetic retinopathy, diabetic papillitis, hypertensive retinopathy was ruled out, which are the differential diagnosis. And provisionally, we suspected it to be post-viral neuroretinitis. And without waiting for the test, since the vision was worse in most of the cases, that is CF 6/36 Snellens or up to CF 1 meter, we started them on oral prednisolone 1 mg per kg body weight after physician clearance and tapered weekly based on the response of the patient. Fundus examination was done with indirect ophthalmoscopy. This is one of the case wherein we can see drastic improvement pre and post treatment after 6 weeks of treatment with oral prednisolone. In the superior part, it is a hazy media with mild vitritis, but in the inferior part of the diagrams, we can see that the vitritis has resolved and the inflammation component of the retina is also resolving. And the optic disc edema also is settling down. Visual recovery of all the patients were from hand movements positive to 6/36 in just 2 weeks of time. And I have plotted the graph subsequently of up to 6 weeks. Optic disc edema and subretinal fluid takes about 2 months to resolve, and it was documented in the OCT on the subsequent follow-ups. These patients were evaluated for all infectious etiologies and were negative for HIV, HPSAG, brucella, dengue, chikungunya, tuberculosis, and syphilis. RA factor and other systemic inflammatory causes were also ruled out. And mainly, COVID was one of the COVID at that time could present to us as a vasculitis. So in all these 19 eyes, COVID was also ruled out. They were all tested negative. So finally, retrospectively, we have put the diagnosis of this whole cluster that presented to us as single episode idiopathic neuroretinitis. This was a vision charted pre-treatment and post-treatment. Here, even with 1 mg per kg body weight of oral prednisolone, only 36% of the patients recovered completely. Neuroretinitis is said to be self-limiting and spontaneous resolution in about 6 weeks. But there are some cluster of cases who, even with treatment, have a poor visual outcome. Again, Again, idiopathic neuroretinitis is further divided into single episode and recurrent neuroretinitis. This is a discussion part. It is commonly unilateral and painless loss of vision with senocentral or arcuate scotoma defect seen on visual field examination, which is consistent with edema in the papillomacular bundle. And the exudates typically appear after 9 to 12 days. Most of the patients have good visual prognosis and the clinical course is self-limiting, but a subset of the patients may have poor visual prognosis. Hence, early diagnosis and treatment is essential for better visual outcomes. So this is how we went about the cases. Since they were all presenting to us with a single episode first time, we started them on high-dose corticosteroids. My conclusion is early diagnosis and aggressive treatment is necessary for a better visual outcome for the patient. And in the next cases, I would like to also evaluate, because a recent article has stated that early changes can be picked up on OCT before the appearance of macular exudates, that is epipapillary infiltrates due to accumulation of inflammatory cells in the vitreous near the optic disc borders, and the inner retinal folds that occur in these cases of neuroretinitis are very characteristic. They are expanding outwards as concentric rings into the macula due to the mechanical effects caused by retinal edema. Thank you.
Yes, sir.
Yes, sir.
Nothing. I wanted to add something. See, because because we also see many neuroretinitis like this, but better to add, my suggestion is better to add some antibiotic, at least after immediately steroid, you have to at least doxycycline, or some people will add Septron also. Better to add antibiotic, and then under the cover of, usually you, whenever patient comes first to you, use antibiotic, get investigation done. Under the cover of antibiotic, better to start steroids, because steroid is a double-edged this one. Because sometimes it may cause other problems also, steroid induced. Okay?
Yes, sir. Yes.
Okay.
Yeah.
Anything,
I just had one more. I just had one query. Like, do you do Weil Felix test also, Dr. Sanjana?
Yes, sir.
At your center, Weil Felix test
Yes,
for these cases to rule out rickettsia,
yes.
That's also. And do you do toxoplasmosis also? Not in neuroretinitis, but in case of isolated retinitis. It's not in such a case. This doesn't look clinically like toxo at all, but
the toxo, we actually send the sample to Lalpat, sir. But we do take samples and evaluate it routinely in our hospital.
Okay, right. Yeah, it's better to start on antibiotics, doxycycline. I found that most of them are positive for Weil Felix. So it's better to start them a course of doxy and then give the steroids. Some patients are there who worsen with steroids alone. What is your opinion, Dr. Vinay?
Sir, actually, like, we have a case series of almost 123 patients of like post-pyrexial retinal microangiitis, like a similar bilateral involvement. Almost it is a multi-centric study. Like a few of my friends, like all of us, like collectively, like we are collecting, and we start like doxycycline only if Weil Felix is positive or any other bacterial thing is coming. Otherwise, like, I don't start like doxycycline for all the patients. And if the macular edema is there, like, or if there is any neurosensory detachment is there, still it resolves better even with the oral steroids itself. But the only problem is like recurrence will be more. Even like in this study, like the follow-up was till 6 weeks, right?
Yes, sir.
Yeah, because like it won't recur like at least up to like 2 or 3 months. After the 3 months, once you are tapering the steroids, when it comes to 10 milligrams or 5 milligrams, suddenly there will be a rebound retinitis. In our study group, there were almost like 18 to 24% of patients who had rebound retinitis, which again we increased the oral steroids, and almost all, like 100% of them, like resolved. And one more key point is like you have already done this HIV. HIV is a very this thing like where CMU retinitis can also present as a post-fever retinitis. So that we need to take as a.
Yeah, I think we're done with the questions and the discussion.
Yes.
Thank you.
Thank you.
Okay. Thank you.
Thank you, Dr. Sanjay. Next, Dr. Narsamma. Are you ready with your presentation? She's logged in here. Dr. Narsamma, you are muted.
Hello, good afternoon, sir. Anu.
Good afternoon, you're audible.
Good afternoon, sir. One second, sir, I'll project my screen. Good afternoon, one and all. I'd like to thank to all the dignitaries present in this session. Myself, Dr. Narsamma, junior resident, and my paper presentation is about dermoretinal manifestations in rickettsial disease. And my chief author, Professor Dr. B.N. Kalpana ma'am, and my guide being Dr. Shilpa ma'am. And basically my study, the objective of my study is to present the visual outcome in the management of the rickettsial retinitis in the patients presenting with and without skin rash. It is a 2-case report, and the patients who reported to our vitreoretinal clinic of a tertiary care center. Basically, I'd like to speak something about rickettsia. It is a zoonotic infection wherein the spread is from animal to human transmission, but the human-to-human transmission is not yet noted. And rickettsia, it is an obligate intracellular gram-negative organism, which is transmitted by the bite of tick, mite, flea, or lice. And rickettsial agents are based on the infection they cause. They are grouped into 3 categories: the spotted fever group, typhus group, and scrub typhus group. And the manifestations are acute febrile illness, headache, myalgia, macular rash, which appears on the 5th day of the fever. And that rash further forms the eschar with ulceration. And patients can also have lymphadenopathy. And if it is to the severe extent, can also have cardiac and cerebral involvement. In rickettsia, we can see ocular involvement also, but usually it is very underdiagnosed condition. Ocular involvement, usually the patients will be asymptomatic or can present the minor ailments like just the diminution of vision or conjunctival congestion. And to the severe extent, they might come with scotomas, floaters in front of the eyes, and all the ocular structures can be involved, coming from the ocular adnexa till the posterior segment. And posterior segment manifestations being predominant and of major importance. They are it can cause retinitis associated with the vasculitis and mild vitritis to some extent, and causing nerve fiber layer infarcts, which is seen as cottonwool spots. And basically the ocular manifestations, it is believed to be due to immune complex depositions from the systemic infection. My case 1, a 16-year-old male presented with blurring of vision in the right eye, which was sudden in onset, not associated with pain, and non-progressive since 1 week. And he also gives history of fever with rash since 3 days. And rash was almost forming eschar-like picture. And is on examination. Hello.
Yes, you're audible.
You're audible. You can continue.
Yes.
I think you're muted now.
Now, sir. Hello.
Okay. Yeah, continue. We can hear you.
This boy presented with the rashes all over the body, predominantly over the upper limb ventral aspects and lower limb also. His visual acuity, when checked, best corrected visual acuity was 6.9 and left eyes was 6.6, and rest anterior segment details were found to be normal. Coming to the posterior segment examination, when done fundoscopy, fundoscopy showed the disc edema of both the eyes with cottonwool spots and my little exudates also along the vessels. And when OCT was performed, OCT was found to be within normal limits. And he was subjected for basic investigations, which were found to be within normal limits, and was treated with IV doxy and oral steroids with tapering dose. And after 4 weeks, he again came for the follow-up. Then it was noted the disc edema was resolved, and the cottonwool spots were reduced, and OCT was normal. And coming to the other case, a 30-year-old male presented with diminution of vision in the right eye since 3 weeks. Even this was also painless and progressive in nature, but he had no history of redness, pain, or any other major ailments like floaters or scotoma. And he had a history of fever, which he tell with mild rashes. On ocular examination, his best corrected visual acuity was found to be in the right eye was 618, and in the left eye was 6, and the rest of the anterior segment examination was normal. On doing fundus photography, there was noted a retinitis patch which involved the macula, and on performing OCT, there was macular edema, and even he was subjected to the investigations wherein he was found to be detected positive for Bill Felix and RT-PCR COVID antibodies. After receiving the treatment of oral doxy and steroids with tapering dose, he was again asked to follow up for after 4 weeks. Then his macular edema was resolved, and retinitis patch was seen to be resolving, leaving no scar. Coming to the discussion part, as told, it is rickettsiosis is an underdiagnosed group of disease which usually presents as acute febrile illness, but it has a high mortality if it is left untreated, and it is prevalent in states like Maharashtra, Karnataka, though only few cases have been reported till date. And in our first case, we had a severe skin eschar with posterior pole involvement involving retinal disc edema with no macular edema, which is usually rare in the post-fever retinitis, as suggested by the Ankush Kawali et al. Studies, and was resolved after IV doxy and oral steroids. And in our second case, our patient didn't have skin rashes to much extent, but his fundus had only retinitis patch, and even he responded to oral doxy and oral steroids. And diagnosis of rickettsia, it is usually clinical and based on the clinical and laboratory findings, like has the skin rash is peculiar, and on serology testings, and doxycycline, it is the first is the line of management for rickettsiosis, though the prevention can be the mainstay management, like avoiding contacts with the mites and having personal hygiene. Coming to the conclusion, rickettsial lesions in the rickettsiosis are similar to the post-fever retinitis. They clear without scarring after the treatment, and when treated with oral doxy and steroids, significant improvement in the visual acuity was there, and central foveal thickness was come back to the normal, and disc edema was also resolved in the 4 weeks. And my references. Thank you. Sir?
Puneet, any questions, Puneet? Puneet or Vinay?
None from my side.
Vinay?
Nothing, sir. Like similarly, the previously, like I told, like don't take it in the other way. Like better get all the investigations. So then only oral steroids or doxycycline, depending upon that.
Yes, sir. Our patient was
a good presentation.
Hello, sir.
Okay, we can go to next presentation.
Hello, sir. This is Dr. Akshay. My antipode is 138, sir. 138.
1382, right?
Yes, sir. Yes, sir. Sir, there is a small query, sir. Actually, I have quiz competition with KOS at another 10 so I want to present now, sir. I'm in holiday.
You want to present now?
Yes, sir. Because another 10 minutes, 15 minutes, I have a quiz competition with KOS.
Okay. Is that okay, Dr. Pradeep? Yeah, I think we can let him present first. And you need to be a little more clear, Dr. Rajshekhar. Your voice is a little, there's a lot of echo or something like that.
Is it clear now, sir? Am I audible? Hello?
Yeah, Dr. Rajshekhar, you can start.
Yeah, thank you, sir.
There's lots of some disturbance from somewhere. I don't know. Request everyone to mute themselves.
Sir, shall I start now? Am I audible to everyone, sir?
Yes, you can start. You're audible.
Good evening, everyone. So, here I am presenting a topic on evaluation of visual outcome in patients with diabetic macular edema post intravitreal triamcinolone histamine injection. My chief author is Dr. Siddharth Vengati, and my co-authors are Dr. Shekhar and myself, my presenting author, Dr. Rajshekhar. Coming to introduction, diabetic macular edema is defined as a retinal thickening within 2 inches diameter of center of the macula, which is resulting mainly from the retinal microvascular changes, which compromises the blood retinal barrier, causing the leakage of plasma constituents into the surrounding retina. So, clinically significant macular edema as given by ATDRS has certain criteria they have given. If it has to fulfill at least one of the three. So according to CSND, retinal thickening in this image you can see retinal thickening within 500 micrometer from the center of the fovea, or even hard exudates with adjacent retinal thickening from the 500 meter from the center of the fovea, or even there is a development of zone of retinal thickening in size, at least a part of it should be within 1 inch diameter from the center of the fovea. So my material methods, it was a prospective study which included 88 patients who are attending the outpatient department of our department. They underwent IVTA as a part of treatment for macular edema. The age of the patient ranged from 35 to 60 years. The study was conducted from October 19 to September 2020. So the included patients were NPDR and PDR. All patients received a complete eye examination, inclusive of best corrected visual acuity using slit lamp examination and even visual acuity with the interocular pressure measurement was done, lens status evaluation was done, and direct and indirect ophthalmoscopy was done of the posterior pole with 90 lens. OCT was done wherever necessary. Evaluation was done at first week, 6 weeks, and 8 weeks post-operative. Coming to the technique of injection, what we use with meticulous aseptic precautions and with topical anesthesia by using 0.5% paracaine. Triamcinolone histamine is used in a single bottle 40 mg per ml, which is drawn in a tuberculous syringe of 1 cc after cleaning it with alcohol wipe. So the needle has been changed to 26 gauge needle, and excess triamcinolone is discarded. Like only it is the quantity was 0.05 and 2 milligram of the TA, that is a triamcinolone histamine. It was injected into the inferior temporal quadrant to avoid drug deposition in front of the visual axis. The needle was removed simultaneously, and a drop of topical antibiotic solution was administered. The eye was patched. Coming to inclusion criteria, all patients with diabetic macular edema having best corrected visual acuity in affected eye of 618 or worse, and those who underwent at least one dose of IVTA as a part of treatment, and those who have given consent has been included in the inclusion criteria. Coming to exclusion criteria, those who underwent cataract surgery are any patients with retromacular traction, uncontrolled glaucoma, family history of POLG, those who receive intravitreal injection along with IVT, like anti-VEGFs, and those with hazy medium, and those who are not failed to give recommended consent, and in one-eyed patients. Coming to the observation, the age distribution, the majority of the age group was between 51 to 60 years, around 34%, and the next common was more than 60 years, around 30%. Coming to gender distribution, females are around 55% in my study. Frequency of the disease in my study was in diabetic macular edema. The NPDR was constituted of 62%, and PDR was 12%. And the patient who IVTA was given the first, second, third dose, and first dose was given to maximum number of patients, around 69 patients was given. Change in best corrected visual acuity after IVTA, number of patients were improved around 55%, and who deteriorated was just 10%. Frequency of eyes showing visual improvement on follow. Majority of the patients shows visual improvement after 4 weeks, around 40%. And the complications associated with IVTA, like the cataract, mainly the posterior subcapsular cataract was more in number. And the number of eyes with raised IOP was also more after 4 weeks, that's around 30% of the cases. Coming to our research, the result of our study suggests that IVTA is an effective tool in the treatment of macular edema, and our patients established that there is a definitive improvement in visual acuity in diffuse macular edema. The most significant improvement in visual acuity was noted in first month, around 4 weeks post IVTA. So 55 eyes showed improvement in the total study period. Coming to discussion, use of experimental corticosteroid, that is biology instrument, was first advocated by Macular for the proliferative requirement. He demonstrated in experimental rabbit model the lack of oxygen toxicity of the triangle estimate. Their results were in agreement with clinical observation of the cases in which corticosteroids were accidentally injected into the eye. Here in our study, it is a prospective study which included 90 years who came to our department. Most of the patients are diabetic macular edema. Many of them have systemic comorbidities like diabetes mellitus, hypertension, dyslipidemia, coronary artery disease. We found that majority of the patients showed a better clinical response following IVT. Apart from decreasing the central retinal thickness, the patient in the study showed significant improvement in the best corrected visual acuity after IVT. So the result of our study suggests that IVT is an effective tool in the management of macular edema, and our patient established there is definite improvement in visual acuity, especially in diffuse macular edema. Coming to conclusion, IVT in the dose of 2 mg appears to be very effective and relatively safe modality of treatment of reducing macular edema, and it has seemed to have definite potential in improving visual acuity. The most optimum outcome was seen at the end of 4 weeks after giving IVT, and improvement sustained till the extent of 8 weeks. The main side effect which was noticed was IOP elevation, which was seen in around 40 patients at an interval of 7 days to 1 month after IVT. So IVT is a favorable and promising therapeutic tool in managing macular edema for certain duration of time with minimum transient side effects. So this was my references. Thank you.
Yeah. I have just one question.
Sure.
What kind of diabetic macular edema, what clinical and OCT picture would be very ideal to give intravitreal steroids?
Clinical, if it is a diffuse macular edema, what we usually see to normal endoscopic examination. If it is a diffuse macular edema, and even in the OCT also, especially the one with the central involvement of macular edema.
Correct. Anything specific in that? You're almost there. Diffuse macular edema, more or less. So mainly in cases with lot of hard exudates, hard exudate plaques. and large foveal, you find these really huge foveal cystoid spaces in the center. So these are very ideal cases. What else would you like to would you consider injecting if not for triamcinolone? If you have a very affordable patient, what?
Yes, sir. Even we can use dexamethasone implant also, sir.
Yeah, very good.
For long term.
Any other questions?
Nothing, sir. As sir said, like usually the steroids will help more in case of like hard exhibits, and even we published a study with the title of Avastin non-responders and anti-VEGF non-responders, even in international conferences. And there the characteristic morphological characteristics which indicates the need for the steroids was the large cystoid spaces at the center.
And even there is subfoveal film also like steroid is used.
And one more question for you. Like in your slides, you have shown like there was a reduced vision in 25% of the patients. Was that reduced vision because of the progression of the diabetic retinopathy or a worsening of the diabetic retinopathy or because of the cataract or glaucoma?
It was because of this cataract developed because of this IVTs. Okay. There was no worsening seen as such after giving IVTs. There was no worsening of diabetic retinopathy, but because of the development of cataract, so there was a reduction of vision, especially the posterior subcategory.
Thank you.
Thank you, sir.
Yeah, Dr. Pradeep, are you ready with your presentation?
Yes, sir.
Dr. Rajshekar has to stop screen sharing.
Yes, sir. Yes, sir.
Good evening, respected judges. I hope my slides are visible.
Yes.
At the outset, I would like to thank the organizing committee for giving me this opportunity. Today, I'll be discussing my paper on the targeted laser photocoagulation of rim aneurysms in diabetic macular edema. Microannualisms are the earliest clinical findings in diabetic retinopathy, and the leaky microannualisms contribute to diabetic macular edema. Aneurysms larger than the typical microaneurysms arising from the capillaries are described in DME, and it has been variously termed such as telangiectatic capillaries, retinal capillary macroaneurysm, and so on. In this presentation, our focus will be on the aneurysms with the rim. These aneurysms arise from the capillary, as we can see over here. In the case of diabetic macular edema, we can see that there is an aneurysm which is not arising from any major artery, but from a capillary level, and we can see that there is a white rim around it. This can be seen on OCT as a hyperreflective rim with a hyporeflective space. So in a retrospective study that we conducted, we noted that in eyes with DME due to capillary aneurysms with the rim, they respond poorly to anti-VEGF and the response to steroids is somewhat moderate. So the purpose of this study was to assess the efficacy of targeted laser photocoagulation in management of DME secondary to capillary aneurysms with rim. So this was a retrospective study. We included cases with DME with capillary aneurysms with rim. We included both the cases which were treatment naive and the cases which had a poor response to intravitreal agents. So the capillary aneurysms with rim were identified on color photograph, and it was confirmed on OCT, and they were localized, and laser photocoagulation was performed with a 100 micron spot to achieve a complete blanching of aneurysm. The patients were followed up every 4 weeks until the resolution of edema, and once the edema resolved, they were followed up every 3 monthly. Moving on to the results, 9 eyes were included in the study. We'll just go through a cases. So case number 1, here we can see that it's a case of DME with presence of an aneurysm with a rim, and post laser photocoagulation, we can see that there is a complete occlusion of this particular aneurysm. This patient was previously treated with bevacizumab with poor response to treatment, and the edema was persistent. So here we can see that this is the aneurysm which is seen as a hyporeflective space, but post laser photocoagulation 2 months later, we can see that it is completely occluded, And at the fovea, we can see that there is a complete resolution of neurosensory detachment.
I think the slides are paused. Slides are not.
Does the other judges also have the same issue?
No, it's moving. The slides are
okay. Sure. Can I continue?
Yes, please. Sir, is there any problem?
Yes, you may continue.
Yeah, thank
you. You will continue because sometimes because of the internet connection, it will be there. Yes.
Yeah.
Thank you. So moving on to case number 2. Moving on to case number 2, here we can see that there is presence of neurosensory detachment with moderate NPDR, and we can see here there is an aneurysm with a rim. And 2 months post laser photocoagulation, it is barely detectable, and we can see that there is complete resolution of neurosensory detachment, and the intraretinal cystoid spaces are completely resolved. And here we can see that on OCT, this hyporeflective space is completely replaced by a homogeneous material, indicating that there is a complete closure of aneurysm. The vision improved to 6.6, and the patient did not had a recurrence of macular edema until 6 months follow-up. So coming to case number 3, this patient was treated previously with multiple doses of bevacizumab and dexamethasone implant with no improvement in macular edema. Here we could see that there is a presence of an aneurysm with a rim, and this patient underwent laser photocoagulation, and 2 months post-laser, we can see that there is a complete occlusion of the aneurysm. And here we can see that there was complete resolution of macular edema with normalization of foveal contour and a complete occlusion of the aneurysm. Here we can see that this is a big aneurysm which is almost completely sclerosed. And the vision improved in this patient also. So this patient did not show any recurrence till 24 months follow-up. So this is the other eye of the same patient in which we considered laser as the primary therapy, and we can see that after 2 months of laser photocoagulation, these 2 aneurysms were completely regressed, and it is completely replaced by homogeneous reflectivity. And here we can see that the central macular edema resolved significantly completely, and we can see that there is a normalization of the foveal contour. This patient had recurrence of macular edema at 18 months due to development of a new retinal the capillary aneurysm with a rim. Here we can see that this aneurysm is responsible for the center involving macular edema. So this patient had a recurrence in his right eye, but the left eye is stable even at 24 months. So moving on to case 5, here we can see that this is an aneurysm. 2 months post laser, we can see it's completely regressed, and the macular edema at fovea is almost resolved. So these are the 5 cases in which we could see that there was a complete resolution. So moving on to a case 6, where we can see that this is an aneurysm which was treated with laser photocoagulation, and this is 2 months, this is 3 months post laser. We can see that there is a complete occlusion of the aneurysm. At the center, we can see that the subretinal fluid is completely resolved, but there is persistent intraretinal cystoid space. This patient was previously treated with ranibizumab, and this patient did not respond to treatment, so the laser therapy was considered in this patient. Due to the significant disruption of the outer retina, the vision did not improve. Case number 7, here we can see that there are 2 small, actually a smaller aneurysm compared to our previous cases, and 2 months post laser, we can see that it is still persistent. It's not completely occluded, so indicating that it may be an incomplete treatment. Similarly, we can see that there is resolution of neurosensory detachment, but the intraretinal cystoid spaces are persistent at 2 months, indicating that he may need further treatment. So these 2 cases had partial resolution. But moving on to another case, case 8, here we can see that there was an aneurysm which was lasered, and 2 months later we see that the hyporeflective lumen is completely obliterated, but there was no change in the macular edema, and he was advised to undergo intravitreal pharmacotherapy. So another case, case number 9, here we can see that there is an aneurysm with the rim, and 2 months post laser we could see that there is presence of hemorrhages around the aneurysm. On OCT, we could see that this hyporeflective lumen, what we can see is completely replaced with the homogeneous material, but there was no change in macular edema, and he was advised to continue with intravitreal pharmacotherapy. So to summarize the results, out of the 9 eyes with center involving DME, 5 eyes showed complete resolution with laser treatment alone. 2 cases showed partial resolution, and 2 cases did not show any improvement. So, and occlusion of aneurysm was complete occlusion of aneurysm was seen in 7 eyes. One eye had almost a similar picture, and one eye showed a minimal hyporeflective lumen within the aneurysm. So 3 cases were resistant to intravitreal pharmacotherapy prior to laser treatment, and they responded very well to focal laser photocoagulation. The limitations of the study are the retrospective nature of the study, a very small sample size, a variable follow-up duration, and we have not assessed the long-term risk involved since the laser is a bit denser and it is close to the center. And the confounding factors such as the systemic status, the glycemic control, the diabetic status, the hypertension, lipid profile are not evaluated in these cases. So to summarize, capillary aneurysms with rim are seen in DME, and it may be associated with poor response to intravitreal pharmacotherapy. It can be identified on color photograph and is confirmed on OCT. Targeted laser photocoagulation results in good response in at least half of the cases. So to conclude, a prompt identification and laser photocoagulation of the aneurysms with rim in DME is helpful in better management of DME, and we can even reduce the treatment burden. Thank you.
Excellent presentation and excellent documentation also, Dr. Pradeep. I have just one question. What were your laser settings for the obliteration of the complete obliteration of the rim aneurysms?
The power we used was it varies. It depends on the amount of the cataract, the media opacity. But the end point was like we should be able to see the blanching of the aneurysm. We should be able to see the white dot over the aneurysm. That's the end point. And we used 100 micron spot size.
Okay.
Sometimes at least around 4 to 5 burns would be required to achieve a complete blanching of an aneurysm.
Okay. And just one more question, how to differentiate it from a retinal artery macular aneurysm? They look very similar, but we just trace the vessel and differentiate it, that's it? Or is there any other way?
As you can see in all the color photographs, you can see that they were nowhere close to any artery.
Artery, okay.
We can see them. The arterial aneurysms, usually we will not be able to see the lumen in the arterial aneurysms in OCT, but we can see the aneurysms, we can see the lumen in the capillary aneurysms actually, but we don't see aneurysms. We only see the wall in cases with arterial macroaneurysm. There are a few studies which have noted that ICGA is better in identification of these aneurysms. They have used the term telangiectatic capillaries. It may not it's both of them may be partly similar, but in all our cases, what we are discussing, we see a rim around that aneurysm, and these are very much amenable to focal laser. Like if we do laser over that aneurysm, it does take. It's not like the small microaneurysm in which most of the time the retina around the aneurysm would take the burn. But in this case, this takes the burn, and we can. The major postulate is that, as we can see, usually the blood would pool within these aneurysms, so that the hemoglobin takes up the laser very well, so that and it's assumed to be slow flow again, because it's not detectable on OCTA. So it's mostly a low flow. So considering that, the blood pools within this aneurysm, so that it takes up laser very well.
Okay. Any other questions?
One question from my side. Pradeep, how many had you cut any cutoff from the fovea, from the foveal region till that means microns, how many microns from the fovea that you have not done the laser or something?
If the aneurysms are at the edge of foveal vascular zone, and if they are within 500 microns from center of fovea, we haven't treated them. They are not part of this presentation.
Okay, Pradeep, okay.
My question was the same as like Raghavendra sir. So in your 4th patient left eye, can you go back to the slide, please, Pradeep? Case number 4, left eye.
Case number, this one.
This, yeah, left eye. Go to the OCT part.
That's why. Yeah, this is
fourth case. Case 4, left eye.
Sir, actually, the case 3, this is the third. Case 3 is left eye of the same patient, and case 4 is right eye of same patient, sir.
Okay. Go back. Go to the OCT. Yeah, the same thing. Case 3. Even here also, it's Even in the next city also, it's very close to the fovea. Like,
yes, sir. This was the first case we treated. Actually, this patient,
after the resolution of the edema only, like we could make out that it is a little bit close to the fovea.
Yes, sir. Like in this patient,
was there any different laser modality was used, or only the double frequency Nd:YAG was used?
Double frequency Nd:YAG only was used, sir.
Okay.
This was
but
actually
since you're not
attempt since he had not responded to any anti-VEGF therapy or steroids for the past 2 years. So it was a desperate attempt in this patient actually. Based on the results of this patient, we started doing other cases also.
Okay, but only thing is you have to follow the patient at long term, because later scarring, it can go to very close to fovea, is usually not advisable.
Yes, sir.
But anyhow, you mentioned in your limitation of study, so that's okay.
This patient we have followed for 2 years and there is no issue till now.
Okay, Pradeep. Thank you. Very excellent presentation.
Thank you, sir.
Thank you, Pradeep.
Okay, thank you. Dr. Rosaline?
Yes, sir.
Okay, you can start, Rosalie.
Next, Dr. Santosh, please be ready.
Okay, sir.
Please start immediately after your next person, no?
Dr. Rosaline, are you there?
Yes, sir. Am I audible, sir?
Yes. Yes, Rosaline, you can continue.
Good afternoon, everyone. Today I am presenting my paper study on evaluation of serum homocysteine in patients with ischemic retinal vascular occlusive diseases. Coming to the introduction, homocysteine is a sulfur-containing metabolite of methionine. The risk factors: homocystinemia is a risk factor for atherosclerosis, including coronary artery disease, peripheral vascular disease, cerebrovascular disease, and venous thromboembolism. A plasma homocysteine concentration exceeding 15 micromole per liter defines hyperhomocystinemia. The most common risk factors for retinal vascular occlusive diseases are arterial hypertension, diabetes mellitus, valvular disease of the heart, and carotid artery stenosis or plaques. Rare causes are arthritis, vascular spasm, and hyperhomocystinemia. Elevated homocysteine levels may act as pathogenic link through which the various risk factors may exert their deleterious effects on the retinal vascular endothelium. The objectives of my study are to assess the level of serum homocysteine in patients with retinal vascular occlusive diseases, to establish the relationship between serum homocysteine levels and the presenting clinical conditions, and to establish relationship between serum homocysteine and severity of diabetic retinopathy. Materials and methods: the patients diagnosed with retinal vascular occlusive disease with visiting the outpatient department of ophthalmology, HIMSS Teaching Hospital, Hassan, were included during the study period of June 2020 to December 2020. Method of collection of data: study type is cross-sectional study, sample size 100, and sampling method is convenience non-random sampling. Inclusion criteria: patient with retinal vein occlusions like central branch and tributary retinal artery occlusions, patients with significant with or without maculopathy, patients presenting with ocular ischemic syndromes. Exclusion criteria: pre-existing systemic hyperviscosity syndrome, hypercoagulable conditions, and systemic autoimmune diseases. Pre-existing ocular disease like glaucoma, uveitis, and inflammatory vasculitis. Methodology: ophthalmic examination was done as follows: best corrected visual acuity, intraocular pressure measurement, detailed slit lamp examination, fundus examination, fundus fluorescein angiography, and fundus photo. OCT was done if required. History of diabetes mellitus, hypertension, hyperlipidemia, cardiovascular disease was taken. Routine investigations like CBC, RBS, ESR, lipid profile, BP measurement was done, and ECG, cardiovascular examination, and physician opinion was also taken. All patients underwent serum analysis of fasting homocysteine levels. Venous blood samples were drawn from patients, and all examinations were performed at 8 hours after an overnight fast. The machine used for serum homocysteine assay was Architect homocysteine. Coming to the results, among the total 100 eyes, 52% were male and 48 were female. Distribution of each pathological conditions: 54 patients had DR, 14 patients had CRBO, 19 patients had BRBO, 5 patients ocular ischemic syndrome, and 8 patients CRAO. Grade of DR: among the 54 DR patients, 31 had severe NPDR, 6 had very severe NPDR, and 17 had PDR.
Distribution among the 33 retinal vein occlusions, CRVO 14 patients, 13 patients BRVO, and 6 patients HRVO. Among the 100 patients, 25 patients, that is 25%, had elevated serum homocysteine levels. Distribution among 25 patients with elevated serum homocysteine, DR 11 patients, CRVO 5 patients, BRVO 3 patients, HRVO 2 patients, Ocular Ischemic syndromes 2 patients, and CRO 2 patients. And distribution among 11 DR patients with elevated serum homocysteine, severe NPDR 3 patients, very severe NPDR 2, and PDR 6 patients. To summarize my results, 25 patients, that is 25% with vascular occlusive disease patients had elevated serum homocysteine levels. Out of these, 11, that is 44% patients had diabetic retinopathy. In DR, it was found that 6 patients, that is 54%, constituted proliferative diabetic retinopathy. Discussion, studies indicate that 15 to 30% of patients with premature occlusive vascular disease have moderately elevated total plasma homocysteine concentration, that is higher than 15 micromole per liter. Pathomechanism of raised serum homocysteine induced vascular occlusive disease. It's due to the direct toxicity to the endothelial cells, synergistic interaction between homocysteine and lipoproteins, and various platelet abnormalities like increased adhesiveness, decreased survival, and increased thromboxane A activity. Promotes the clotting cascade via inactivation of protein C, activation of coagulation factor 5, and increased vascular smooth muscle proliferation and inhibition of the thrombomodulin. In our study, it showed that 25% patients with vascular occlusive disease had raised serum homocysteine levels apart from the usual risk factors for vascular occlusions. Elevated homocysteine level may act as a pathogenetic link through which various risk factors exert their deleterious effects on the promotion of diabetic retinopathy. In the development of DR, the pathomechanism is it accelerates the cell injury and proliferate the smooth muscle cells to alter motor activity. Then cell injury at the level of retinal capillaries, and the relationship between PDR and plasma homocysteine levels may be related to C677T mutation in the gene coding for the methylene tetrahydrofolate reductase. And in our study, 25% patients had raised homocysteine levels, among which 11, that is 44% patients had diabetic retinopathy, and most common clinical presentation was PDR. Coming to the conclusion, elevated homocysteine levels is a risk factor for retinal vascular occlusive disease and acts not only as an independent risk factor, but also a contributing factor for the severity of DR. There is a direct relationship between levels of serum homocysteine and DR. Hence, understanding and characterizing the homocysteine role in the pathogenesis of DR could help in identifying novel target to combat this blinding disease. Hence, it is imperative that assessment of levels of serum homocysteine is important and should be done in vascular occlusive disease. Further studies in this regard are warranted. Financial disclosure nil. These are my references. Thank you.
Just one question. Would you like to investigate every patient of retinal vein occlusion for serum homocysteine?
Sir, according to recent trends, it is actually better to evaluate all the patients for serum homocysteine levels.
Okay.
Better, but my one suggestion is at least any patients who are young without any risk factors like hypertension or anything, better to because otherwise serum homocysteine is usually not advised for every patient. See, as other person presented CRP and serum homocysteine, there are n number of study of other patients for diabetic and other thing. Better to keep it as reserve as serum homocysteine for young patients who are like less than 40 or something, stroke in young, like these situations are there. No? Similar for them, it is better to advise serum homocysteine, not for other patients.
Correct. Even I agree with Dr. Raghavendra. And for all vein occlusions, you can just do the routine ones initially, like just check the blood pressure. Most of them will be undiagnosed hypertensives for all your surprise. And check the lipid profile. Some of them will be hyperlipidemic without any high blood pressure. So just do these two first, and then if it's still not making any sense, probably you can go in for serum homocysteine. What are your thoughts, Dr. Vinay?
Yes, sir. I totally agree with Raghavendra, sir. Even I am not advised for all the patients.
In diabetic retinopathy, do you do serum homocysteine? Actually, this is the first time I'm hearing about it.
Yes.
If patients have raised serum homocysteine in diabetics, there is early progression to proliferative diabetic retinopathy, sir.
See, Rosaline, rather than you can see that, because see in moderate NPD or anything, if you see more of cottonous spots or more of vascularity, more of venous toxicity, that is itself is an indication for this one. Clinically only you can diagnose rather than how it is progressing or not, rather than ordering for serum homocysteine.
Yes, sir.
Okay.
Good presentation.
Okay. Yeah. Good presentation.
Thank you.
So, thank you. Dr. Santosh?
Yes, sir.
Be ready.
Okay, sir. My slides are visible, sir.
Yeah.
My title of my paper is Demographic Profile and Associated Risk Factor in Retinal Vein Occlusion. There are no financial interest. Introduction. Retinal vein occlusion is one of the second most common acquired retinal vascular abnormality after diabetic retinopathy. RVO is a frequent cause of sudden onset visual loss. A recently published pooled analysis of 11 major studies from United States, Europe, Asia, and Australia has found the incidence of branch retinal vein occlusion to be 4.4 per 1,000 persons, whereas CRVO is 0.8 per 1,000 persons in general population. Although various factors are apparently involved in the production of retinal vein occlusion, the exact cause is unclear. Predisposing conditions of retinal vein occlusion include diabetes mellitus, hypertension, hyperlipidemia, systemic vascular diseases, open-angle glaucoma, hyperviscosity, increased ESR, certain medications, and smoking, etc. CRVO can be divided further into ischemic and non-ischemic types. This distinction among types of CRVO is important because up to 2/3 of patients who have ischemic variety will develop iris neovascularization and neovascular glaucoma. Objectives of my study: to study the demographic factors and clinical presentation of retinal vein occlusion, and to study the predisposing factor associated with retinal vein occlusion and compare the individual risk factors for central and branch retinal vein occlusion. Method: source of data, outpatient department of ophthalmology. It is a descriptive observational study conducted during September 2019 to February 2020 for 6 months. Sample size 50 patient. Inclusion criteria: patient with hypertension, diabetes, obese patient, smokers, patient with hyperviscosity, and all patient willing to give consent. Exclusion criteria: patient with multiple comorbidities, ISD cases, and pregnant ladies. The current study was carried out in the Department of Ophthalmology, Mandya Institute of Medical Sciences, Mandya, for a period of 6 months from September 2019 to February 2020. All the cases in which retinal vein occlusion was observed for the first time in the OPD during the study period were included in the study, excluding the old diagnosed cases. A total of 50 cases were found and examined meticulously. Each one of the selected cases was subjected to complete sequential evaluation for the etiopathological and clinical study with full cooperation of respective patient and the attendant, as the nature of study was properly explained to them prior to the procedure. All selected were questioned thoroughly to know the presence or absence of the cardiopulmonary abnormalities, thromboembolic phenomena, diabetes mellitus, any ischemic episodes, chronic infection, hypertension, etc., and the findings were noted accordingly. Due importance was given to the history of glaucoma with reference to its duration and medication. All patients underwent for detailed systemic and ocular examination, including visual acuity, anterior segment slit lamp biomicroscopy, applanation tonometry, fundus examination, gonioscopy, OCT, fundus fluorescence angiography as per need, and laboratory investigations like routine blood urine analysis were done in each cases. Blood sugar was done to know the glycemic status of patient. Kidney function test was done to know the status of renal function. Lipid profile, BT-CT, prothrombin time was also done. Results: sudden onset deterioration of vision was predominant complaint in 43 patients, that is 86%, and only 3 cases complained of gradual onset of diminution of vision, and 4 patients complained of floaters, and 1 patient complained of sectoral field of vision loss. Association of pain was reported by 7. In CRVO group, increased IOP was found in 3 cases, and 4 cases were found to have RAPD. Results: there were 32 male patients and 18 female patients, and among the 32 male patients, 19 were with BRVO, and 2 patients with diabetes, 11 with hypertension, 3 with obesity, 2 are smokers, and 1 with hyperviscosity, whereas in CRVO, 13 males were with CRVO, 8 with diabetes, 3 with hypertension, 1 is obese, and 1 with hyperviscosity syndrome. And among 18 females, 12 females were with diagnosed with BRVO, and 1 is with diabetes, 9 with hypertension, 1 with obesity, and 1 with hyperviscosity. And among 6 CRVO females, 3 are having diabetes, 2 hypertension, and 1 was obese. The association of systemic disease with the cases of RVO was found to be statistically non-significant, more than 0.05. Association of refractive status and intraocular pressure with retinal vein occlusion was found to be statistically insignificant, and there was no statistical significant association between lab findings and RVO. Discussion: retinal vein occlusion is relatively most common retinal vascular disorder secondary to diabetic retinopathy. Since the time of Lipids in 1854, Leber in 1977, and Michael in 1878, the exact etiology and pathophysiology of disease is yet to be fully established, making the disease progression unpredictable. In our study, age group of patients suffering from retinal vein occlusion varied from 39 to 75 years. Mean age of presentation in male was 57.6 years, and for female it was 56.1 years. A male preponderance was seen in most of the published series of central vein occlusion, and we have encountered a similar prevalence of male preponderance in our study. In our present study, we observed that 50% of cases of retinal vein occlusion were suffering from hypertension. In CRVO patient group, 26% cases were hypertensive, and in BRVO, it was 64.5%. Thus, incidence of hypertension in our study was higher in patients with BRVO than CRVO. In our study, 14 patients with RVO were diabetic, 78% were in CRVO group, and 22% in BRVO group. Thus, the incidence of diabetes in our study was higher in a patient with CRVO than BRVO. In our study, we had found 12 patients were obese, 4 had BRVO, 2 had CRVO. In our study, we had found only 15% of CRVO patients with elevated IOP, and in case of BRVO, it was nil. No case of angle closure was detected. In our study, 25% and 46.8% patients with CRVO and BRVO cases respectively were hyperopia. Conclusion: sudden onset deterioration of vision is the predominant presentation in RVO. It occurs in all age groups, though the middle and older age group are commonly affected. Socio-demographic distribution of both CRVO and BRVO is statistically insignificant. That is, they have no association. Systemic hypertension, DM, hypercholesterolemia, hypertriglyceridemia, hypermetropia are the common predisposing factors for developing retinal vein occlusion. These are my references.
Santosh, one question.
Sir.
Is retinal vein occlusion and glaucoma is correlated? Is there any correlation between them?
In retinal vein, central retinal vein occlusion, 3 patients were having open angle glaucoma. But in branch retinal vein occlusion, no patients having any, there is no rise of IOP.
No. I'm asking in general, Santosh. Not pertaining to your study. I'm asking in general, is there any correlation between central retinal vein occlusion and glaucoma?
Correlation means CRVO may progress to neovascular glaucoma.
Okay. Any other questions? Vinay and Puneet?
Dr. Santosh, sorry, maybe I have missed the slide. Was there any definition, like how do you define this obesity and hyperviscosity in your study?
Oh, sir. Based on body mass index, patient with more than 26 taken as obese patients. Hyperviscosity, well, PTCT and APTT, I advised, sir. Based on that, I categorized them into hyperviscosity.
Okay, but only BTCT and APTT like won't give you the hyperviscosity picture.
True. Yeah, I agree with that.
Fine. Thank you.
Okay. Next, Dr. Shilpa.
Okay.
Thank you, Santosh. It was a good presentation.
Thank you.
Next, Dr. Shilpa.
Hello.
Yes, you're audible.
Shilpa. You're audible. You can start.
Sir, am I audible?
Yes, Shilpa, you're audible.
Good evening, everyone. I'm here to present paper on retinitis. Myself, Dr. Shilpa, being the presenting author, and my chief author is Dr. Sandhya Dharwadkar, ma'am. To start with, posterior retinitis is an infectious or para-infectious uveitic entity caused by bacterial or viral agents and seen mainly in tropical countries. Ocular manifestations typically start developing within days to weeks after the onset of febrile illness. So most of the patients would come to an ophthalmology OPD when their systemic features would have already faded. Owing to its seasonal variation and its correlation with community outbreaks, it's also known as epidemic retinitis. And also, because of the fundus findings, it's also known as multifocal retinitis. Objective of our study was to observe and analyze the demographic profile, clinical picture, and response to treatment in infectious retinitis.
This was a cross-sectional study done on 50 patients in our department. A patient would usually come with complaints of diminution of vision. Their visual acuity was assessed with using Snellen's chart and fundus examination with indirect ophthalmoscope with +20D lens. It was done at the presentation and the patient was reviewed weekly till 3 months. Basic investigations were sent like complete blood count, blood sugars, and also the serological investigations were ordered. The treatment included oral steroids in all cases, except CMV retinitis, where only highly active antiretroviral therapy was initiated. Systemic antibiotics for specific organisms were also added as per the diagnosis. Results of our study was the age group was between 18 to 45 years old, females being 60% and males 40%, mostly unilateral, that is up to 84%, and 16% were bilateral and asymmetric. Most of the cases were idiopathic post-fever retinitis, and 22% were rickettsia, 16% toxoplasma, 10% typhoid, 6% CMV retinitis, and dengue and chicken pox 4%. The presenting visual acuity was usually 6/6 up to CF counting fingers ½ meter, and the final visual acuity, the prognosis is usually good with steroids and also antibiotics in some cases. That is up to 64%. It was 6/6 to 6/9, followed by 6/12 to 6/18 in 28%, and 6/24 to 6/16 8%. This is one of the cases in our department. This was post-pyrexal retinitis, idiopathic, and this was a follow-up after the steroids, and steroids were tapered according to the clinical response. So retinitis has to be differentiated funduscopically from other retinopathies as well as among the other organisms, since it may mimic other conditions and pose a diagnostic challenge. A study post-fever retinitis done by Srilata Vishwanath et al. Concludes that irrespective of the cause of the fever, clinical presentation of cases was similar with inner retinitis at the posterior pole and a favorable response to steroids, suggesting a possible immunological basis for this condition. A study by Padmamalini Mahindra Das et al. Concluded that the serological investigations and molecular diagnostics are required to pinpoint exact etiological agent. In most of the cases, the course of the disease is self-limiting with good visual outcomes without any recurrences. Deepak Sundaram et al. Study conclude that a combination of oral doxycycline and oral steroids as a treatment option showed improvement in BCVA and central foveal thickness in rickettsial cases. Pratik Shenai et al. Studied the demographics, clinical features, and treatment outcomes with systemic steroids in eyes presenting with post-fever retinitis from central India, and found that there has been an increase in the prevalence of post-fever retinitis cases. Multifocal retinitis, retinal hemorrhages, and vitritis were the most common clinical findings. The retinitis resolved with improvement in vision following steroid therapy in all eyes. Conclusion here is multiple organisms may cause a retinitis-like picture, usually affecting young to middle age group with no general predilection, and show good response to tailored management. Also, the concern is that the patient has to be counseled and tested for HIV to rule out CMV retinitis, as it has a good prognosis with heart. These are my references. Thank you.
Okay, I have one question, Dr. Shilpa. If you see a patient with a retinal lesion, a yellowish white lesion, you're not sure if it's a cotton wool spot or a retinitis or a hard exudate. So what will you look for on OCT to help you identify that it is a retinitis?
These would have hyperreflectivity of retinal layers, sir.
Very good.
In case of rickettsia, it would be only inner retinal layers. After shadowing, in case of
okay, that's fine, fair enough. Another thing you can look for is you can look for vitreous cells. So you know that's very easy to pick up on OCT if you can't see obvious vitritis. So you can actually see the vitreous cells on OCT, and that will help tell you it's an inflammatory pathology. Right. Any other questions?
Dr. Shilpa, it was a nice presentation. how many patients like in your study were on only oral steroids?
Actually, all the patients were on steroids, sir, except for rickets cell patients and typhoid patients with they were given antibiotics.
Okay, and CMV and toxoplasma and all?
CMV, most of them were not tested positive, so we had to send for the serology first, and then they would have started the treatment.
Patients were CMV retinitis and 16% were toxoplasma. Were only steroids were given, or then along with that, like you treated this CMV and toxoplasma also?
No, toxoplasma we had given Septran PS, diphenhydramine plus sulfamethoxazole.
Okay, that means like the only steroids was maybe 38%.
Yes.
Okay, fine. Though like all of us are getting like so many cases of post-viral retinal microangiitis, the only thing is like we need to compile.
Yeah, there are a lot of cases of retinitis, post-fever retinitis. I agree.
Yes. We are getting at least weekly 1 or twice.
One good thing in this study was like you have taken all the references from an Indian studies. Like the previous studies were Indian studies, because like even the demography also like it plays a role. So you won't see so many cases in Western or any other area. That's one good thing. Thank you. It was a nice presentation.
Okay.
Thank you.
Nice presentation, Shilpa. Next. Dr. Shreya?
Yes, sir, I'm there.
Dr. Shreya, yeah, please. You can start your presentation.
Yes. Good evening, everyone. My name is Shreya Jain, and I'm talking about a free paper on the topic correlation of macular thickness with serum lipids in patients with type 2 diabetic retinopathy. My chief author is Dr. Rajni Kadrima. I have nil financial interest. Objective of my study is to determine and to compare the proportion of diabetic patients with and without diabetic retinopathy with increased macular thickness and to correlate a macular thickness with the serum lipid profile. Introduction. Diabetes mellitus is a common disease and is of two types, type 1 and type 2. Mostly patients with type 1 diabetes mellitus develop diabetic retinopathy in 15 years. And in patients with type 2 diabetes, chances of developing diabetic retinopathy increases with the duration of the disease. Out of the 246 million people with diabetes mellitus, about 1/3 have diabetic retinopathy, and 1/3 of these might have serious vision-threatening retinopathy, defined as severe retinopathy or macular edema. Diabetic macular edema is characterized by swelling or thickening of the macula due to the sub or intra-retinal collection of the fluid in the macula due to the breach in the blood-retinal barrier. Now, optical coherence tomography is a non-invasive technology that enables to detect and monitor even the subtle changes in the macular thickening. OCT images can be used to assess qualitative and quantitative measurements, which are important in the early stages of diabetic retinopathy, when structural changes are not yet appreciated in slit lamp biomicroscopy. Now, blood lipid metabolism is known to play a role in pathogenesis of diabetic macular edema. Coming to materials and method, this was a cross-sectional study which was carried out on 12 diabetic patients with diabetic retinopathy and 8 diabetic patients without diabetic retinopathy, which I'm taking as a control. Place of the study was in the outpatient department of ophthalmology in AJ Institute of Medical Sciences and Research Institute. Now, according to American Diabetes Association, diabetes is defined by the criteria of fasting blood glucose level of more than 126 milligram per deciliter, or ppbs of more than 200 milligram per deciliter, HbA1c of more than or equal to 6.5%, and random blood sugar of more than or equal to 200 milligram per deciliter. The patients diagnosed as diabetics, according to the criteria given by the American Diabetic Association, at least 1 year prior to the study, and started on anti-diabetic drugs were included as diabetics. Now, detailed history was taken and ophthalmic evaluation was done. Dilated fundus examination was done in slit lamp biomicroscope using 90 diopter lens and through indirect ophthalmoscope in both the groups. Diabetic retinopathy patients were classified according to ETDRS classification for diabetic retinopathy. Then serum blood lipid levels were measured. Spectral domain OCT images were obtained with the Zeiss Primus 200 spectral domain OCT using the automatic real-time eye tracker to eliminate motion artifacts. 2 measurements were recorded here: central subfield macular thickness and macular volume, defined as the mean retinal thickness and the total volume within the central 1 mm surrounding the central circular zone, respectively. My inclusion criteria for the cases would be patients who are willing to give the informed consent, patients with type 2 diabetes mellitus more than 1 year duration with diabetic retinopathy, and those patients in whom serum lipid profile has already been done. For controls, patients who are willing to give, again, the written consent, patients without any systemic illness, patients with type 2 diabetes mellitus, but without diabetic retinopathy. My exclusion criteria for cases where patients who are not willing to give the consent, or patients with type 1 diabetes, or patients with high myopia or hypermetropes, any types of previous retinal treatment, or any ocular trauma such as blunt and penetrating injuries, history of any other systemic illness, patients with glaucoma and retinal diseases not associated with diabetes. For control, patients, again, not willing to give consent, history of any systemic illness, or any ocular trauma such as blunt and penetrating injuries. Coming to result of the study, this was a comparative study. It was conducted on 40 eyes of 20 patients, and the statistical tests used were Student's t-test and Pearson's correlation test. For all statistical purposes, right eye is taken into consideration. Coming to the demographic data of the patient, mean age in cases were 55 years and in controls were about 57 years. Majority of the patient in cases belonged to male, and in the control group, it belonged to female, around 75%. Mean duration of the diabetes was found to be 8 to 9 years in both the groups. The patients divided according to ETDRS classification showed majority of the patient in this study belonged to moderate NPTR, next being the diabetic macular edema. Comparing the OCT parameters between the cases and controls, there was increase in subfield macular thickness and increase in macular volume in about 25% and 41.7% respectively in the cases group. But there was no increase in macular thickness and macular volume in the control group. Percentage of lipid profile among the two groups. Among the cases, there was decrease in HDL in about 75% of the patient and increase in LDL in about 58.3% of the patients in cases group, whereas in control group, there was increase in triglycerides in 25% and VLDL in 25%. Comparing the OCT parameters between the cases and controls using the Fisher's exact test p-value, there were significant parameters in the OCT macular volume with p-value of 0.019 and with the HDL parameter with 0.006 of p-value. But the correlation of OCT macular thickness with lipid profile using the Pearson's correlation found there was no significant correlation between the OCT subfield macular thickness or any of the lipid profile parameters. Coming to the discussion, in this study, we demonstrated that there is no correlation between the macular thickness and serum lipid profile in patients with and without diabetic retinopathy. Benares et al. Found no association between serum lipids and diabetic retinopathy, diabetic macular edema, and macular thickness or volume measured using time domain OCT in patients with various stages of diabetic retinopathy. Our results are consistent with the findings from the study. But however, the study which was conducted by Mariko et al. Found that a higher level of LDL cholesterol was associated with increased central subfield macular thickness and macular volume. Now, they studied the relationship between macular thickness and volume as measured by OCT and its association with serum lipids as risk factors for diabetic retinopathy or macular edema. Low density lipoprotein cholesterol was positively linked with the macular thickness and macular volume. That is, each 1 millimole liter increase in LDL was associated with a mean increase in macular thickness of 6.52 microns and macular volume of 0.0047 millimeter cube. Furthermore, in this study, the small sample size is the limitation. Coming to the conclusion, the result of the study shows that there is significant increase in macular volume among patients with diabetic retinopathy as compared to patients without diabetic retinopathy. But there was no correlation which was found between the macular thickness and lipid profile among both the groups. Thank you.
If you see large hard exudate plaques at the macula, what would you investigate the patient for?
If there was hard exudate?
If you see large hard exudate plaques and deposits macula, what will you investigate the patient in a patient with diabetic retinopathy?
We would do all the we would see the diabetic duration, sir, and even HbA1c and
anything else. Particularly, I mean, this is actually you should investigate for serum lipids. What I wanted you to say. If you see large amount of plaques, hard exudate plaques with it's an indication that you must probably work up the patient's lipid levels,
yes.
And include that also in the management.
Okay, sir.
I even agree with Puneet, because any patients who are having more macular edema, though your study told you there is no correlation, but still, if it is a non-dissolving macular edema with hard exudates at the this one, better to investigate and put them on anti-lipid drugs. Otherwise, it will help in your resolution. Otherwise, your lasers will not take up, treatment will not be successful. So better.
Yes.
Okay.
Yes, sir.
Vinay, anything to add, Vinay?
No, sir, completely agree.
Okay.
So usually, like, there are many studies, like, even which have showed like everything, including total cholesterol, LDL and VLDL, is definitely correlated with the progression of diabetic retinopathy and diabetic macular edema and macular thickness also.
Yes, sir. There was a parameter of LDL which showed significance with the macular thickness in many of the studies.
But maybe one thing what I observed was like maybe the number of cases were less here.
Yes, sir. Yes, sir.
Okay, good. Thank you.
Thank you, sir. Thanks so much.
Okay, good presentation. Is Dr. Sushmita?
Yes, sir.
You can start, Dr. Sushmita.
Good afternoon, everyone. My name is Dr. Sushmita. I'm presenting a paper on pigmentary retinopathy with mitochondrial myopathy. My chief author is Professor Dr. B.N. Kalpana. Coming to introduction, mitochondrial diseases are a clinically heterogeneous group of disorders. They can be due to mutations of nuclear DNA or mitochondrial DNA. The eye is frequently affected along with muscles and brain. Coming to ophthalmic manifestations, these include cataract, retinopathy, optic atrophy, cortical visual loss, ptosis, and ophthalmoplegia. Four such important clinical entities secondary to mitochondrial DNA abnormalities having ophthalmic manifestations are MELAS, that is mitochondrial encephalopathy, lactic acidosis, and stroke-like illness, MIRF, myoclonic epilepsy and ragged red fiber myopathy, KSS, Kansai Syndrome, LHON, Leber's hereditary optic neuropathy. Coming to the objective of the study, it is to report a rare case of mitochondrial myopathy with pigmentary retinopathy. It's a study design, it's a rare case report. Source of study is Vitro Retinal Clinic of a tertiary care center. Coming to the history, a 14-year-old male presented with history of diminution of vision since 5 years, which is progressive and painless in nature. History of seizures since 6 years. History of difficulty in walking since 2 years. History of inability to speak since 2 years. And there was no history of recent trauma or ocular surgery. And there's no similar history in the family. Coming to general physical examination, patient had proximal muscle weakness and diminished deep tendon reflexes in biceps, ankle, and knee. Patient had a lower limb proximal muscle weakness, genu valgus, ataxic short step gait. Coming to ocular examination, both eye, it has an end case nystagmus. In the right eye, there was 30 degree of exotropia. Both eye showed mild ptosis, and there was restriction of movements in all cases. The rest, everything was normal. Visual acuity could not be tested because the patient was not cooperative. Coming to fundus examination, on fundoscopy, we found pale disc with pale background retina, highly attenuated blood vessels, with stippled peripheral retina and macular area, simulating salt and pepper retinopathy. In investigations, OCT of both eyes showed generalized retinal thinning with foveal thinning and loss of retinal pigment epithelium and photoreceptors at the fovea. Coming to the workup, in blood investigations, almost all the blood investigations were found to be normal, within normal limits. ECG had normal sinus rhythm. 2D echo also showed normal valves and chambers, normal biventricular function, no obvious shunt lesions or patent ductus arteriosus or coarctation of aorta or any conduction defects. In the MRI, mild cerebral and cerebellar atrophy and optic atrophy was found, and they were suspecting it to be a mitochondrial disorder. And in ERG, it showed presence of advanced retinitis pigmentosa changes. In VEP, both eyes showed poorly formed waveforms with prolonged P100 latency, which suggested optic nerve axonopathy. Coming to advice, according to the advice of neurologist, we started the patient on anti-epileptic drugs. He was advised to continue the anti-epileptic drugs, which he has been using since 6 years. That is tablet carbamazepine, tablet olanzapine, tablet clonazepam. He was also started on mitochondrial cocktail to alleviate his symptoms. Coming to discussion, MELAS onset is usually within 2 to 10 years, presents with generalized tonic-clonic seizures, recurrent headaches, recurrent vomiting, anorexia, seizures, ophthalmoplegia, salt and pepper retinopathy, optic atrophy, macular dystrophy, sensitive neural hearing loss, heart defects like left ventricular hypertrophy, and regional wall motion abnormalities. In KSS, that is Kansai Syndrome, usual onset is less than 20 years, presence with progressive external ophthalmoplegia with the pigmentary retinopathy, with any of the following three, that is cardiac conduction defects, CSF protein, concentration of more than 100 milligram per deciliter, or cerebellar ataxia. They also have skeletal muscle weakness, hearing loss, seizures. KSS minus or PEO minus, PEO plus, they are the cases of pigmentary external ophthalmoplegia that meet some of the criteria of KSS, but not all of them. LHON, onset is between 15 to 35 years, most common in males. Pathognomic features include circumpapillary telangiectatic microangiopathy, pseudodisc edema, and absence of leakage from the disc on fluorescein angiography. In MURF, presence usually in early childhood, presence with myoclonus, generalized epilepsy, ataxia, sensory neural hearing loss, peripheral neuropathy, optic atrophy, and ragged red fibers on muscle biopsy. Kansai syndrome was first described in 1958 by Thomas Kearns and John Syrie. It usually presents before the age of 20 years, more commonly in males. Our patient was also a 14-year-old male. And Kansai syndrome occurs as a result of sporadic mitochondrial DNA deletion, commonly 4977 base pair deletion. There was no significant family background that was seen in our patient, suggested it was most likely sporadic in nature. They have a classical triad of progressive external ophthalmoplegia, pigmentary retinopathy, and cardiac conduction defects. But in our patient, he had just progressive external ophthalmoplegia, mild restriction of gaze in all directions, and pigmentary retinopathy, but no conduction defect as such. According to B. Kobu et al., cardiac manifestations were seen in 57% of patients with KSS, and in our patient, 2D echo and ECG were found to be normal. Other disorders associated with KSS are cerebellar ataxia, nystagmus, dementia, deafness, protein levels, increased protein levels in CSF, proximal myopathy, exercise intolerance, thyroid disorders, hypoparathyroidism, Addison's disease, dysphagia, that is due to eclasia, and renal tubular acidosis. Our patient was found to have cerebellar ataxia, end-gaze nystagmus, and proximal myopathy. Coming to conclusion, since the patient met most of the criteria for Kansai syndrome, but not all of them, we suspected it to be a case of Kansai minus or progressive external ophthalmoplegia plus syndrome. So when the mitochondrial disorders are suspected, meticulous examination should be performed to confirm the diagnosis, and systemic investigations for cardiac conduction defects and endocrine disorders, etc., which are potentially preventable causes of death and disability. As ophthalmologists, what we can offer is symptomatic treatment for some of the most disabling manifestations of this disorder. There's no financial disclosure. Thank you.
Yeah, I have one question. In your patient, you found foveal thinning in both the eyes and the macula, right?
Yeah, yes, sir.
In some of the patients, you may find cystoid macular edema. What would you like to inject in such a case?
For treating that edema, sir?
Yeah. Will you inject?
I'm not sure of that, sir.
Okay, so actually it's better not to inject because most there is cystoid macular edema found in retinitis pigmentosa and other such heredomacular degenerations. So the thing is, here the fluid accumulation is mainly because of RPE dysfunction. It's a angiographically negative leak. Okay, it's angiographically negative edema. It does not leak on fluorescein angiography. You mentioned that in one of your slides. So giving anti-VEGF or steroid will not really help in such cases because it is not because of increased vascular permeability the edema is occurring. So make sure you do not I have seen so many patients with the RP with cystoid macular edema being given intravitreal steroids everywhere else. There is no point giving it for them. It's not going to help because there's an RP dysfunction. So this is something you should know.
Right.
Yeah. Anything else? Any questions?
No.
Agree with Puneet, sir. And one more thing in your management, like in your last slide, like you written symptomatic treatment for the ophthalmological this thing.
Yes, sir.
Low vision aids is one of the best thing you can do.
Yeah, I agree. Low vision aids is something we should really work on in India, I think, because that's the only thing you can actually do for them.
Yes, even if the vision improves, even at least for 10 to 15%, they'll be happier.
Correct.
True.
Thank you.
Thank you, sir.
Dr. Tejaswini?
Yes, sir.
You can start, Tejaswini.
Okay, I'll share the document. So once there is a problem, I'll just share the document. 2 minutes.
You have to share screen. If you're on Zoom, just press share screen.
I'm doing it. It's showing it not able to upload the document.
Is it, are you doing it from your laptop or are you doing it from your phone?
Laptop itself, sir.
Okay, so if you should, there should be an option called share screen. If it's there on your laptop, it should show actually.
Recording in progress. So 1 second, I'm just trying it, sir. Give me 2 minutes, sir.
No problem.
Can I see in share? Speak out, sir. Because I'm able to see, but here it's not displaying at all.
There will be one more drop down from above. Even you can share screen from that.
Okay, I'm trying.
Do you have an updated app of the Zoom? I mean, is it an outdated version or something? I mean, just check on that.
Yes, I do.
This one you can present like that only, no problem.
Yeah, just present it.
Just present it, no problem.
Okay, 1 second, sir. Good afternoon. Sorry for the inconvenience, sir.
No problem, no problem. You can continue. Start.
Here is a clinical study, which the title of the study is Clinical Profile in Patients with Vein Occlusion with Hyperhomocystinemia. I am Dr. Tejaswini R, presenting author, and the chief author is Dr. B.N. Kalpana, ma'am. Financial disclosure is nil. Coming to the introduction part, retinal vein occlusion is one of the most common retinal vascular diseases. The most common causes of vein occlusion are hypercoagulative states, collagen vascular diseases, lymphoproliferative disorders, malignant hypertension. Homocysteine is an amino acid derived from methionine, which can be converted to cystine. Coming to the metabolism of homocysteine, methionine is an amino acid converted to homocysteine used with the help of methionine synthetase enzyme with the help of vitamin B12 and the methyl group donated from folic acid cycle. And in turn, homocysteine is converted to cystathione via cystathione beta synthase enzyme and vitamin B6. Coming to the pathology in vein occlusion, increased homocysteine level will cause increased tissue factors and decreased cofactor activity of thermomodulin. These in turn lead to increased prothrombotic state and increase in fibrin levels in the circulating blood. The basic pathology of the disease is atherosclerosis. Mild to moderate elevation of plasma homocysteine is reported as a risk factor for atherosclerosis in the coronary, cerebral, and retinal vasculature. Clinical features depend on the site and degree of atherosclerotic changes. Coming to the objective, it is to analyze the clinical profile in patients with vein occlusion with hyperhomocysteinemia. The methodology was a hospital-based retrospective analysis of 11 eyes of 11 patients with vein occlusion with hyperhomocysteinemia who received intravitreal triamcinolone for cystoid macular edema was conducted. Demographic data, detailed history, systemic illness, initial visual acuity, anterior segment examination, fundoscopy findings, OCT findings were noted and analysis was made. Objective data recorded include demographic data, type of vein occlusion, homocysteine levels, history of systemic illness, central foveal thickness using OCT. Materials and methods. Inclusion criteria were patients with hyperhomocysteinemia defined as levels more than 12 micromoles per liter and patients with vein occlusion who received intravitreal triamcinolone for cystoid macular edema. Exclusion criteria, patient whose levels were less than 12 micromoles per liter, that is negative for homocysteine, and any media opacities obscuring the fundus view. The results were as follows. 11 patients with retinal vein occlusion were included in the study. 4 patients had CRVO, which was 36.36%, and 6 patients had BRVO, which accounted for 54.54%, and 1 had tributary vein occlusion. Male to female ratio was 6:5, and mean age was 42.8 plus or minus 6.19 years. Initial BCVA was logMAR 0.8 plus or minus 0.3. Central foveal thickness was 408.8 plus or minus 201.6 micrometers. Homocysteine levels were 18.29 plus or minus with mean deviation 2.199 micrometers per liter. The mean homocysteine levels in CRVO was 20.18 with mean deviation of 4.05, and in BRVO was 17.58 with mean deviation 1.54 micromoles per liter. And 5 out of 11 were recently diagnosed as hypertension. 1 was both diabetic and hypertensive. 3 had dyslipidemia status. Among 11, 1 patient had recent history of cerebrovascular accident. Coming to the discussion, in our study, we found that BRVO was the most common type of vein occlusion, but the homocysteine levels were more raised in CRVO patients. In a study done by couple D et al., showed an incidence of 37.5% CRVO and 62.5% BRVO, which is similar to our study. In a study done by Jan Lehetskoy et al., hyperhomocysteinemia manifested as an elevated plasma of homocysteine is now a widely recognized risk factor for human vascular disorders and ischemic and thromboembolics too. Conclusion, hyperhomocysteinemia has been linked to increased incidence of vein occlusion, hypertension, stroke, which becomes unnoticed among young patients. Assessment of homocysteine levels, especially in young patients, helps in predicting systemic comorbidities, and hyperhomocysteinemia associated with vein occlusion, especially in young patients, helps us to prevent systemic morbidity, thus early treatment is required. Thank you.
Any questions?
No, Prince.
No, sir.
No.
All right. Okay. So I think we are done with our free paper session. Thank you to all the participants for a good presentation, and all the best.
Thank you, everyone. Thank you, Puneet sir, and thank you, Raghavendra sir.
Thank you to all the judges.
Thank you also to Puneet and Vinay for coordinating the discipline. And thank you for all the participants. Okay, best of luck.
ನೀನೇನ್ ಹೇಳಿದೆ ನಾನು 2:30 ಒಂದ್ಸರಿ ಟ್ರೈ ಮಾಡ್ತೀನಿ ಅಂತ ಟೋಲ್ಡ್ ನೋ.
ಇಟ್ ವಾಸ್ ಶೇರಿಂಗ್ ಅಲ್ಲ,
ಅವರು ಮಾತಾಡೋ ನೀನ್ ಶೇರ್ ಮಾಡ್ಬೋದು, ಟ್ರೈ ಮಾಡ್ಬೋದು, ಹೋಗುತ್ತಾ ಇಲ್ಲ ಅಂತ.
ಹಂಗ್ ಮಾಡಿಲ್ಲ ನಾನು. ಡಾಕ್ಯುಮೆಂಟ್ಸ್ ನಂದು ಕಾಣ್ತು PDF. ಇನ್ ಮಾರ್ನಿಂಗ್ ಹಂಗೆ ಆಯ್ತಲ್ಲ, ಕಂಡಿರ್ಲಿಲ್ಲ, ಆಮೇಲೆ ಕಾಣ್ತು, ನಂದು ಕಾಣ್ತು ಅಂತ ಸುಮ್ನೆ ಅದ ನಾನು.
PDF ಅಲ್ಲಿ ಇದೆ ನಿನ್ ಫಾರ್ಮೆಟ್.
ನಾನ್ಸೆನ್ಸ್ ಯಾ, ನಾನು ಪ್ರೆಸೆಂಟೇಶನ್ ತಾನೇ ಕಳ್ಸಿದ್ದು.
ಯಾಕೆ ಬರ್ತಾ ಇದೆ?